Hi, people, teacher, and friends. Welcome to a new video. My name is Claudio Mar Alvarado Ramos. I will talk about is neurologic features in severe SARS Cov-2 infection. My social networks are Facebook, Claudio Alvarado, Twitter, iCloud Alvarado, and YouTube, Claudio Omar Alvarado. Good. Definition. Respiratory viruses can penetrate the central nervous system, nerve invasion, affect both neurons and glial cells, property known as neurotropins, and induce various neurological pathologies, neuroviolences.
Cough, shortness of breath, you're probably familiar with all of those symptoms of COVID-19, but there seem to be some other symptoms as well popping up that are unexpected. Tonight, a Valley doctor, part of an international study, reveals some of the clues to ABC 15 investigator Dave Biskobing.
COVID-19 is an upper respiratory infection, so most people, even doctors, expect fevers, coughs, trouble breathing. But neurologist Dr. David Wang says there are many who have symptoms that are different.
So almost 2 to 3 out of 10 patients with truly COVID-19 infections may have these symptoms without the so-called typical respiratory complaints.
Dr. Wang is with the Barrow Neurological Institute in Phoenix. As the outbreak began, he partnered with a team of doctors in Wuhan, China, the epicenter of the disease.
They tracked 214 patients who had confirmed the diagnosis of COVID-19. And then they had some interesting findings.
Those findings just published in the Journal of the American Medical Association. They show 36% of COVID-19 positive patients had neurological symptoms, from dizziness, headache, to loss of taste, smell, and/or vision, and even stroke.
Initially, people always felt that neurological manifestations should not be common.
The team published its findings so that doctors and nurses don't overlook neurological symptoms as an unexpected but common clue for COVID-19. Quote, during the epidemic period, clinicians should consider neurologic manifestations to avoid delayed diagnosis or misdiagnosis and prevention of transmission. And as for the long-term effects, Dr. Wang says that's largely unknown.
The ones that are early on, such as loss of smell or taste or body aches, will disappear when you recover. Stroke, hard to tell. The other clotting issues, it depends on how extensive that is.
I'm investigator Dave Biskobing, ABC 15, Arizona.
Applications in medicine. Edward et al. Demonstrate 20 years ago that human coronaviruses are capable of inducing both acute and persistent infection in neuronal cells lineage, oligodendrocytes, and human neurologia. The human coronavirus has been shown to be neuroinvasive and cause flaccid paralysis and demyelination in animal models. The coronavirus spreads from the olfactory bulb to the brain stem and spinal cord.
A study of COVID-19 patients in the Chinese city of Wuhan, from where the pandemic originated, found coronavirus could lead to serious neurological complications in perhaps as many as 1/3 of all patients. In the study of 214 hospitalized COVID-19 patients in Wuhan, researchers reported more than 35% had neurological complications, including decreased levels of cognition, stroke, and muscle damage. Their findings, published in the journal JAMA Neurology on April 10th, found 36.4% of those studied had neurologic symptoms. Among patients with more severe infections, 45.5% showed neurologic manifestations. Not all patients with these symptoms exhibited common manifestations of the disease, namely a sore throat, dry cough, and diarrhea. The news comes after previous reports that many COVID-19 patients experience anosmia, or the loss of smell, hyposmia, a reduced sense of smell, and dysgeusia, the distortion of the sense of taste. These reported symptoms may indicate other ways in which the coronavirus could affect the brain. Separately, France's National Union of Dermatologists Venereologists, or SNDV, has reported that certain skin dermatological conditions may possibly be associated with COVID-19 infection. In an April 6th press release, the organization said these symptoms include appearance of pseudo-frostbite of the extremities, transient hives, and sudden onset of persistent, sometimes painful redness.
Good. Pros and cons. Pros, it does not affect all patients, only patients of serious states. So if it can be prevented to reach more complicated states. Cons. Patients with CNS symptoms have lower levels of lymphocytes, platelet counts, and higher levels of blood urea. Nitrogen compared to those without CNS symptoms.
We thought for a long time that once you have it and you're done with it, but turns out that that's not the case. There are thousands of patients now complaining of the fact that they have persistent symptoms. The fever goes away, and all the other symptoms, the cough and other things, and now they're developing other kinds of symptoms. The more common ones seem to be that they have this brain fog, chronic fatigue, malaise, lymphadenopathy. So these symptoms are reminiscent of what we call as ME/CFS. And that's not all that surprising because a lot of viral infections have been associated with this syndrome. These things are happening later in the course of the infection, suggesting that there's an immune component to it. So, the virus goes down and the immune system gets hyperactive, and it can cause a variety of different types of neurological symptoms. And oftentimes, by the time you see the patient, you don't really know what infection they had, and the virus is never figured out, and it's too late to figure out what virus they have. Now that's not an excuse any longer. You know exactly what virus caused it, and you know exactly what the syndrome is, and you know exactly what happened in between. So I think it's an unfortunate situation, but you can use it to your advantage to try and understand these diseases that we haven't been able to for a long, long time.
The study is composed of two cohorts, patients who are acutely ill, who would be followed from the time of the onset of their symptoms out to 1 year. And then we'll be getting patients who've been treated at the outside hospitals who would be enrolled after their acute illness, and to see again the consequences in terms of their cardiac, their pulmonary function, as well as their kidney function, renal function. And we're really trying to enroll not just the critically ill patients. We're very interested in also the young person who might have an infection. They lose their sense of smell and taste. They have a fever. They feel kind of like they've had a bad flu, and they get better. So those people are very interesting to look at, simply because what are the consequences? How do they get better? And how does that differ from someone in a similar age group who doesn't get better and who deteriorates and requires an ICU admission?
I should apply in Ecuador. Of 214 patients with COVID-19, research has shown neurological symptoms. 36.4% of patients were more common in patients with severe infection. 45.5% according to their respiratory status, which has included acute cerebrovascular events, disturbance of consequence, and muscle injury. In conclusion, although it is not yet possible to estimate the magnitude of patients with the new virus who have classic distinguishable neurological symptoms and syndromes, experts have clarified that COVID-19 affects the central nervous system, peripheral nerves, and their muscles.
When people are sick, when their respiratory system is failing, that will have adverse effects on the brain because of poor oxygenation and other metabolic effects that are consequence on the brain. Those things we know as serious, but we also know that those are not direct effects of the virus on the brain itself. There are bits of information that have come out from a number of studies of looking at clinical evaluation of patients that would suggest that there is nervous system direct involvement by the virus, but the reliability of those studies is still in question. Stroke is one of the conditions that has been seemingly at higher incidence in patients who have involvement of the body by the COVID-19. And the mechanism by which stroke occurs in the brain is unclear in this circumstance. It's thought that a lot of it might just be worsening of pre-existing conditions. People who have diabetes, who have hypertension, who have other smoking history, where they have damage to the blood vessels already and are predisposed to stroke already, and now are being stressed from a respiratory perspective by this intense illness, and therefore it precipitates a stroke as a consequence of that. So that may be a more likely mechanism than that there is a specific injury to the brain blood vessels that's causing stroke. The principal things that we'll see from a neurological viewpoint will be changes in mental awareness, cognition, troubles with difficulty of interaction or ability to interact within the environment. I think, again, one of our concerns is how much of this is going to be long-lasting, how much of this is just a temporary effect of the metabolic disturbances. So those are very much uncertain points at this time.
Thank you very much for your attention.